Welcome to this short vignette on perspectives and future directions in multiple myeloma. My name is Carol Ann Huff, and I'm an Associate Professor of Medicine and Oncology at Johns Hopkins in Baltimore, Maryland. Multiple myeloma has become a chronic disease. Over the last 10 to 20 years, we have markedly improved survival for patients with multiple myeloma. And in the year 2016, there are more than 100,000 patients alive with multiple myeloma. As you can see, the survival is improved even in the most recent time for which we have data available, 2006 to 2010, and will continue to improve as we have introduced new therapies. The median time to first relapse with current therapies is now 3 to 4 years, and in the last 12 years, we have had 10 new agents approved by the FDA for multiple myeloma in the United States. Where this has all come from is an increased understanding of the biology of the myeloma tumor cells within the bone marrow microenvironment and the immune response that exists in patients with multiple myeloma. As you can see on the slide, there are multiple avenues that people have been looking at to target, which have culminated in the approval of medicines to treat myeloma, as well as new and emerging therapies. These range from signal transduction pathways to epigenetic modulation, unfolded protein response, and immune responses and immune dysregulation in patients with multiple myeloma. There are many agents that are under investigation targeting these, but what this has led to is an improvement for our patients. With initial therapy for myeloma, our goals are similar regardless of the patient: to achieve a deep, rapid, and durable response, to improve performance status and quality of life, and to not limit the ability to mobilize peripheral blood stem cells in the event that stem cell transplantation is used for this patient. Generally, a 3-drug combination is preferred, although there may be select populations with very low-risk disease for which a doublet will be sufficient. Comorbidities raise the risk of toxicity, but our goal is ultimately to maximize the duration of response. With answers have come more questions. In particular, is there an optimal regimen and duration of therapy? And does this differ for younger versus older patients, for example? On this slide, you can see summarized several of the 3-drug regimens that have been widely studied and used. At the top, bortezomib, lenalidomide, dexamethasone, followed by carfilzomib, lenalidomide, dexamethasone, and other regimens listed there. What I draw your attention to is that with these new regimens have led to improvements in overall survival, with overall survival rates at 18 months of 97% with bortezomib, lenalidomide, dexamethasone, 96% at 3 years following carfilzomib, lenalidomide, dexamethasone, and with ixazomib, lenalidomide, dexamethasone, 94% at 12 months. All of this has led to improvements in survival for our patients with multiple myeloma and leads to the recommendation to use a 3-drug regimen for initial therapy. We have had several trials looking at maintenance therapy, both following transplantation and in the absence of transplantation, and all of these trials have demonstrated an improvement in remission duration on average by 18 to 24 months in improvement. But what was found at the recent ASCO meeting by Michelle et al. And colleagues in a meta-analysis of these trials post-transplantation is there is not only an improvement in remission duration, but an improvement in overall survival for patients receiving lenalidomide maintenance. While there is a risk of secondary cancers and there are toxicities related to these agents, the evidence overwhelmingly supports the recommendation for maintenance therapy for patients post-transplantation or in the absence of transplantation. As we've had improved response rates to therapy, we have also then begun to identify new strategies for measuring response, and in particular, tools to look at minimal residual disease. These are currently research tools, but are rapidly progressing to approval, in particular, likely next generation sequencing, which can detect 1 × 10⁵ or fewer tumor cells. As you can see in this slide from the French myeloma group looking at lenalidomide, bortezomib, dexamethasone with or without transplant, achieving MRD negative status predicts for improvements in progression-free survival. While we do not have overall survival data available as yet, I suspect, like with other trials showing improvements in progression-free survival and followed later with longer follow-up by overall survival benefits, we may in fact realize an improvement in overall survival when we achieve a negative minimal residual disease status. Minimal residual disease assessment is still a research tool. There are new response criteria that are forthcoming incorporating this, and likely will have approval of one of these tools within the next couple of years. But even if patients achieve MRD negative status, they will still relapse. A key question or key questions are, with the introduction of this, can we better optimize therapy for individual patients? Can and should we change therapy based on the results of MRD testing? And maybe this will help us derive optimal approaches for individual patients. Monoclonal antibodies have emerged in the treatment of multiple myeloma in the last year with the approval of daratumumab, and recently presented at ASCO was data looking at bortezomib dexamethasone with or without daratumumab. And as you can see on this trial, the addition of daratumumab to bortezomib dexamethasone more than doubled the progression-free survival at 1 year, being approximately 60% with daratumumab and bortezomib dexamethasone versus not quite 30% for bortezomib dexamethasone alone. Again, evidence that these therapies can be additive and adds to our ability to better treat patients with myeloma. So our future directions, how will we approach treatment in the future, or how do I hope we will approach treatment in the future? With induction therapy, I believe, based on the available evidence, that a triplet-based approach will be recommended for most, if not all, patients. Perhaps with the addition of a monoclonal antibody, either in selected patients, or if we can improve the depth of remission of the regimens with monoclonal antibodies now in all patients. But most importantly, I think for therapy for myeloma, we need to have selection that is informed by patient-specific profiles, which are likely going to be based on genetic changes of the disease. Our goal should be to achieve minimal residual disease negativity in all patients if we can. There may be a patient population that is not required for, and additional studies will hopefully help elucidate that. Maintenance therapy is recommended for all patients, but perhaps there are patients in whom this can be omitted. Perhaps patients who achieve MRD negative status without it may be able to be maintained without long-term maintenance therapy. Inevitably, patients with myeloma will recur, and I would advocate that we will be looking for targeted therapy at the time of relapse, again based on specific profiles. But with each question that we've answered come many more questions and more opportunities to improve our care for myeloma patients. What is the role of transplantation? Can we limit that to patients in some situations, or is it in fact a vital element in our treatment paradigm? Where will immunotherapy play? Not just monoclonal antibodies, but the emerging T-cell-based therapies in the form of CAR T-cells, immunizations, and other immunologic strategies, PD-1 inhibitors, etc. Can we cure myeloma? Are we closer to a cure? I think we're closer to that, but I don't think we're there yet. And perhaps as we learn more, we may be able to even prevent patients, particularly those with smoldering myeloma, from actually ever developing active myeloma, which will ultimately improve the long-term outcome for our patients, both now and in the future. I thank you for your attention.